Welcome to the deep dive. Today we are really putting on our loops, aren't we? We're magnifying the sort of forgotten foundation of knee stability.
Yeah, exactly.
We're not here today to just rehash the ACL or PCL. I mean, everyone knows those.
Right, the blockbusters.
Exactly. Our mission today is to take a really deep, almost surgical dive into the dense material covering the structures that actually support them. We're talking about the often overlooked yet critically important posterolateral corner, the PLC, and its counterpart, the posteromedial corner, the PMC.
That's absolutely right. And, for those of you listening who might be managing complex trauma cases, or maybe you're grappling with why a seemingly perfect ligament reconstruction still ended up with residual instability.
Yeah, that nagging instability.
This deep dive is really essential. We're kind of shifting gears here, moving from simple textbook anatomy, where, ligaments are just drawn as single lines.
Right, nice and neat.
It's exactly. To really understanding the complex reality. The fascial layers, the intricate tendon-arm attachments, and, crucially, the interplay between them. As surgeons, as clinicians, if you miss the pathology hiding in these corners, well, you often compromise the long-term prognosis for the patient. It's that critical.
And the evidence really suggests that as a community, we've probably been underdiagnosing this for decades.
Oh, absolutely.
When we look at the prevalence, the numbers for these injuries, especially in acute knee trauma, the gap between what we used to think and what, say, advanced imaging is showing us now, it's actually quite shocking.
It is genuinely startling. I mean, historically, before standardized MRIs and routine arthroscopic correlation became the norm, the prevalence figures for PLC injuries, they were reported as low as, maybe 6% of acute trauma cases?
6%. That really suggests it's almost a surgical rarity, something you might see once in a blue moon.
Exactly. That was the thinking. But the modern reality, it's dramatically different.
Okay, so what are we seeing now?
Well, modern, more comprehensive studies, they show that PLC injuries actually occur in up to 21% of acute knee trauma cases.
21%? That's more than triple the old number.
It is, and it gets even more compelling when you start dissecting the associated structures, looking beyond just the core PLC components. The iliotibial band, the ITB, injured in a staggering 58% of acute trauma cases.
58%.
Yeah.
Over half. Over half of all acute knee trauma patients have some kind of injury to their ITB complex.
That's what the data suggests.
That percentage is just enormous. It really speaks volumes about, the systemic underdiagnosis of these lateral stability issues we've been dealing with. So why? Why was that historical 6% figure such a gross underestimate compared to the 21% we see now?
Well, the problem really lies in the mechanism of injury and how these patients present. See, isolated injuries just to the PLC on its own, they're incredibly rare. When a patient sustains significant high-energy trauma, the overwhelming majority, we're talking 80, maybe 90%, they have concurrent injuries.
Yeah.
Usually it's the ACL or the PCL that's also gone.
Right, the big ligament tear.
Exactly. And the dramatic instability, the gross laxity caused by that primary cruciate ligament tear, it just completely dominates the initial clinical picture.
Ah, okay. So the patient comes in, maybe with a massive PCL tear. Their tibia is just sagging backwards visibly.
Yep.
And the rotational instability, the maybe more subtle instability caused by the PLC tear, it just gets swept under the rug because everyone's understandably focused on that catastrophic PCL failure right in front of them.
Precisely. You put it perfectly. It's like trying to find a leaky faucet when the entire house is on fire.
Right. You deal with the fire first.
You prioritize the fire, of course. But if you don't eventually go back and fix that foundational structural issue, that leaky faucet, the corner instability, you run straight into what our sources call the graft failure time bomb.
The time bomb, that sounds ominous.
It is. Because if we overlook, or critically, if we undertreat a lateral or medial supporting structure deficiency, the knee just remains persistently unstable. It's subject to abnormal rotation, abnormal forces. And the seminal research, by Noyes and others, demonstrated this really clearly. Inadequate treatment of these secondary stabilizers dramatically increases the risk of cruciate ligament graft failure. Doesn't matter if it's ACL or PCL.
Right.
And that inevitably leads to poor functional outcomes for the patient down the line.
So, okay, let me see if I get this right. If you perform a meticulous, absolutely textbook, anatomically correct ACL reconstruction,
Perfect surgery.
So the lateral corner, the PLC, is insufficient, maybe a grade 2 tear that was missed or underestimated.
Yeah.
You're basically asking that brand new, expensive graft to fight against rotational instability that the corners were supposed to control.
Exactly.
It's like you've rebuilt the house perfectly, but the foundation on one side is cracked. The whole structure is just doomed to experience these weird, abnormal strain patterns.
That structural analogy holds up perfectly. The corners provide absolutely crucial static and dynamic rotational control. If that control is absent, that new graft is under excessive stress from day one. It just sees abnormal external rotation or excessive shear forces, and that leads to it stretching out over time, or sometimes outright failure.
Wow.
So the very first imperative for success before you even pick up a knife is meticulous identification of every single component injury preoperatively.
Okay, so meticulous diagnosis is key. But that demands we all speak the same language, right? A standardized language.
Absolutely.
But diving into the source material for this, the language surrounding these lateral knee structures, it seems less like standardization and more like, I don't know, the Tower of Babel sometimes. It's confusing.
You couldn't describe it better. Honestly, the primary barrier to clear communication and therefore accurate diagnosis in this specific field is the nomenclature. It really is. The naming conventions for all these little structures, they differ wildly across surgical literature, anatomical textbooks, even imaging reports. And that creates significant friction, especially when you're trying to integrate new research findings or just talk to colleagues across different institutions.
Yeah, I saw Laprede's systematic review mentioned in our sources. He traced this confusion back over, 250 years, documenting centuries of just basic anatomical disagreement on what to call things.
That review is really enlightening. Looking back over 250 years of published work, it just underscores how deep this historical confusion runs. And the central culprit, the term that really embodies this chaos, is the arcuate ligament.
The infamous arcuate ligament.
Infamous is right. Our sources, backed up by, modern anatomical dissection and imaging correlation, they strongly advocate for basically dropping this term entirely from our vocabulary.
Just get rid of it.
Pretty much. Because it has almost as many definitions floating around out there as there are actual distinct component structures in the posterolateral corner itself. It's just too ambiguous.
Can you walk us through maybe a couple of examples of that historical ambiguity? I think seeing how one single term was used to describe completely different physical structures really highlights the clinical danger.
Sure. Let's consider the literature. Back in the day, there was a highly influential paper, Seebacher and colleagues, detailing the anatomy of the PLC, a classic paper.
Right.
In that paper, they used the term arcuate ligament to describe a key structure they observed. But critically, they did this because they hadn't yet recognized the specific separate existence of the popliteofibular ligament, the PFL.
Okay, so they saw something arching over, didn't recognize the PFL as distinct, and just called the whole thing arcuate.
Essentially, yes. So their arcuate term was, in effect, substituting for what we now clearly identify as the PFL complex. That's definition number one, a stand-in for the PFL.
Okay, definition one.
Exactly. Then, later on, sometimes a subsequent publication, maybe even from the same institution just years later, would come along and redefine the arcuate ligament.
Redefine it.
Yeah. And this new definition might correspond only to, say, the capsular arm of the short head of the biceps femoris, a completely different physical structure.
Wow.
Other authors use the term to describe the fibulofibular ligament, the FA whale.
So hang on. Depending on which journal you read, or maybe even which decade you pulled the article from, if a surgeon read in the notes, okay, we need to repair the arcuate ligament, they might be thinking PFL, someone else might be thinking capsular biceps arm, and a third might be thinking FFL.
Precisely.
That sounds like a recipe for surgical misadventure, to put it mildly.
It absolutely is. I mean, even Laprade himself, in his efforts to bring some order to this chaos, defined the arcuate ligament as having two limbs, the oblique popliteal ligament medially, and then a lateral limb composed of multiple things, the PFL, the fibulofibular ligament, and the biceps capsular arm, all bundled together.
So even trying to fix it resulted in a complex definition.
Right. But the real takeaway, and our sources really emphasize this, is that if a single term can vaguely describe half a dozen different critical structures just because they happen to form a sort of arched appearance, you just have to stop using it. The mandate is clear. We need to standardize our language. We should favor terminology based on consistent anatomic attachments and clear, reproducible surgical and imaging landmarks. Things like the inferior lateral genicular artery or the popliteus tendon attachments, things everyone can agree on.
And this whole need for standardization, it isn't just some historical footnote, right? It's not a solved problem. We've had a major anatomical clarification just recently with the sort of rediscovery and detailed mapping of the anterolateral ligament, the AL.
That's a perfect example. The clarification of the AL anatomy, confirming it as a true ligamentous structure, distinct from just a capsular thickening. It was a huge, highly publicized event. And it shows how this process of renaming, refining, standardizing anatomical terminology, it persists even today. If confusion still reigns over a basic historical term like arcuate, you can imagine the challenge in accurately reporting pathology in complex, oblique, newly defined structures like the ALL.
Okay, so the confusion with the ligament itself is bad enough, but then it sort of metastasizes, right? It spreads beyond the ligament and creates ambiguity in diagnostic imaging, specifically around the term arcuate sign.
Yes, this is a really critical point, especially for communication between the radiology team and the surgical team. The term arcuate sign is just as ambiguous as arcuate ligament. Why? Because it's been historically used to describe two distinctly different osseous avulsion fractures.
Two different fractures called the same thing.
Yep, and they each carry radically different clinical and prognostic implications.
Okay, let's break that down. What's fracture number one? The first arcuate sign. This seems to relate to the bigger, sort of more global lateral failure.
That's right. Definition 1 refers to the osseous avulsion of the fibular head itself, a chunk of the main fibula head. This involves the insertion of the fibular collateral ligament, the FCL, and usually large portions of the biceps femoris tendon complex as well.
Okay, FCL and biceps. Big players.
Big players. And because the powerful biceps muscle is involved, these fragments tend to be larger, and importantly, they can be retracted proximally, pulled upwards by muscle contraction. Seeing that signifies a massive lateral structural failure.
Okay, big fragment. Pulled proximally. Got it. Now, what's the second type of fracture that also got lumped under the arcuate sign umbrella?
That's the much smaller fracture of the fibular styloid process, just the pointy tip. This typically measures only, say, 8 to 10 millimeters in length, very small.
Tiny compared to the head avulsion.
Exactly. And it involves the insertion of the PFL, the popliteal ligament, and possibly the fibulofibular ligament as well. But here's the critical clinical link. Because of the mechanism of injury that usually causes this, often hyperextension with a posterolateral force, these small styloid avulsions are highly associated with a concurrent PCL injury.
Wow. Okay. That is a huge clinical difference packed into one ambiguous term. A surgeon reading arcuate sign positive in an initial ER report could be thinking, okay, maybe a straightforward FCL repair.
Right.
But if it actually means the small styloid fracture, they might suddenly need to be prepared for a combined PFL reconstruction and a complex PCL reconstruction as well.
Precisely. If that initial imaging report is ambiguous using outdated terms, it just slows down preparation. It necessitates potentially getting additional confirmation scans or leads to delayed or suboptimal surgical planning. So our sources are unanimous on this point.
Yeah.
Drop both arcuate ligament and arcuate sign.
Just be descriptive.
Be accurate. Be descriptive. Say, for instance, osseous avulsion of the fibular styloid involving the PFL insertion, or large avulsion fracture of the fibular head involving the FCL and biceps femoris. And that kind of precision prevents delayed diagnosis and greatly prevents misdiagnosis.
Okay, so step one, use the right words, speak the standardized language. Step two, the next challenge, is actually seeing these often small, oblique, sometimes fiber-thin structures on imaging.
Right.
We know, of course, that the clinical exam, doing your drawer test, the varus valgus stress, the pivot shift, that's ultimately what determines the need for surgery, the functional instability.
Absolutely. The exam is king for the indication.
But in the acutely injured knee, which is often incredibly swollen, guarded by muscle spasm, intensely painful, getting a truly reliable physical exam can be, well, nearly impossible sometimes.
That's where MRI becomes indispensable. In that acute setting, MRI is crucial for documenting the full extent of the soft tissue injury. It maps out the damage, which then directly informs the surgical strategy. However, just relying on conventional standard MRI protocols introduces a really significant potential pitfall: the 2D limitation problem.
Okay, the 2D limitation. When we order those standard 2D sequences, the axial, coronal, sagittal, oblique views we see every day, what's the technical limitation there that causes us to potentially miss something small and important, like, say, the fibular ligament?
Right. So conventional 2D sequences, they're primarily designed to give you high in-plane resolution. That means you get excellent detail within the slice itself. You can see the meniscus tear beautifully in that coronal slice.
Okay.
But they typically achieve this using relatively thick slices, often 4 millimeters, sometimes even thicker. The fundamental physics issue, the limitation, is that the through-plane resolution, that's the ability to resolve structures that run perpendicular or obliquely through the slice, is generally 4 to 6 times worse than the in-plane resolution.
4 to 6 times worse.
So.
Okay. So if your slice is, say, 4 millimeters thick, and you have a tiny oblique structure like a slender little ligament maybe running at a shallow angle across that thick slice.
Which gets blurred out. You simply miss it, or you might see only a small, indistinct, partial volume artifact where the ligament signal gets averaged with the surrounding fat or muscle within that thick 4 millimeter volume. That small, maybe hair-like ligament, like the FE you mentioned, or an oblique segment of the FCL as it courses downwards. It's just inconsistently identified. It gets averaged out, leading to false negatives saying it's intact when it's torn, or maybe misinterpretation of what looks like discontinuity when it's really just the ligament dipping out of plane.
That technical limitation sounds like the perfect setup for missing precisely these subtle but high-stakes corner injuries.
It absolutely is.
So what's the solution? What's considered the new gold standard now for accurately assessing this really complex, three-dimensional anatomical architecture?
The consensus, which is firmly supported by the literature cited in our sources, is moving to 3D isotropic imaging sequences.
3D isotropic. Okay, what does isotropic mean in this context?
Isotropic means equal in all directions. These sequences acquire the data not as individual slices, but as a true 3D block or volume of data. And they do this using tiny volume elements or voxels that are typically less than 0.8 millimeters in size in all 3 dimensions, X, Y, and Z.
So tiny cubes of data instead of thicker rectangular slabs.
Exactly. The key is that the resolution is virtually equal in all 3 planes. That's the isotropic part.
And the big benefit of having that equal high resolution in all directions is you can manipulate the data afterwards.
Precisely. Because you have this high-resolution 3D data set, you can sit at a workstation and reformat the images into any plane you want. You're not stuck with just axial, coronal, sagittal. You can specifically create an image plane that lines up perfectly along the true, often oblique or helicoid course of the FCL or the PFL or the popliteus tendon.
Tailor the view to the structure.
Exactly. And doing that maximizes the signal coming from the structure itself and minimizes those partial volume artifacts we talked about with 2D. You see the ligament clearly along its entire length.
Do we have good data actually comparing how well we can visualize these critical structures like the PFL using standard 2D versus these newer 3D techniques?
Oh, absolutely. The evidence is quite compelling. There's a study by Rajaswaran and colleagues mentioned. They used a high-resolution 0.8 millimeter isotropic 3D sequence, specifically a WED sequence. And they found the visualization rate for the popliteofibular ligament jumped dramatically to 91% of cases.
91%. Okay, compared to what with 2D?
Compared to only 71% visualization using the conventional 2D coronal oblique plane, which was the best 2D view for it.
Wow, a 20% jump in visualization. That's not trivial for a ligament that, as we just discussed, is critical for stability and dictates surgical approach.
Not trivial at all. It's potentially the difference between recognizing the need for reconstruction versus missing it, which can lead to failure down the road.
Right. Now, for those of us, ordering the scans or maybe looking at the technical sequence sheets, these 3D isotropic sequences, they go by different brand names depending on the MRI vendor, right?
They do, and it's helpful to know the common ones. If you're working with a Siemens machine, you'll likely hear the sequence called SPACE.
SPACE, okay.
With GE scanners, it's often called CUBE.
CUB.
And Philips typically utilizes the name VISTA.
SPACE, CBE, VISTA. Got it.
And beyond those names, most specialized orthopedic imaging centers now incorporate some form of 3D fast spin echo, or 3D FSE, sequence with isotropic voxel sizes often getting down below 0.6 millimeters. They build these right into their routine knee protocols specifically to capture this fine posterolateral and postremedial detail.
Makes sense.
And if you actually look at figure 10.1 in the source material, particularly the reformatted 3D images shown there, the clarity you can achieve in visualizing, say, the FCL attachments is really exquisite. That's detail that would likely be quite ambiguous on a standard, thicker 4 millimeter 2D slice.
Okay, so 3D isotropic is the way to go. But even with the best imaging sequences, we still face imaging artifacts, right? Things that can confuse the picture. One constant challenge, certainly for me as a resident reading knee MRIs, is dealing with increased signal within a tendon. How do you reliably figure out if that bright signal is a genuine tear or just physics playing tricks on us.
Ah, yes. You're talking about the famous, or perhaps infamous, magic angle effect.
That's the one.
This is a purely technical artifact based on physics, and frankly, it leads to a huge number of false positive diagnoses for low-grade tendon sprains or tendinosis if you're not careful.
How does it happen?
It occurs specifically when highly ordered anisotropic collagenous structures, so basically ligaments and tendons, happen to be oriented at approximately 55 degrees relative to the main magnetic field of the scanner, the B0 field.
55 degrees, the magic number.
The magic number. When the collagen fibers hit that specific angle, there's an artificial increase in their T2 signal intensity. The tendon just looks brighter on the fluid-sensitive sequences, mimicking pathology like edema or fluid within the tendon substance.
So the knee could be clinically rock solid stable, patient has no symptoms there, but the MRI report comes back saying low-grade sprain of the FCL simply because that ligament happened to lie at 55 degrees in the scanner.
That's a very common scenario, yes, especially with structures like the popliteus tendon and the FCL, whose natural oblique courses often put parts of them right at that magic angle.
So, practically speaking, how do we differentiate this common artifact from true, clinically relevant pathology?
Well, first, you absolutely must know the expected anatomical courses of the ligaments and tendons most susceptible to this, like the popliteus and FCL. Know where they typically show this effect.
Okay, know the anatomy.
Second, you look for secondary signs of injury, and you always cross-reference with other imaging sequences, particularly proton density sequences where magic angle is less pronounced. A true tear will usually show other signs, maybe clear structural discontinuity, fluid actually tracking along the tear path, or hemorrhage and edema in the surrounding soft tissues, maybe even bone marrow edema adjacent to the attachment.
Right, look for the company it keeps.
Exactly. The magic angle effect typically presents as a more uniform, somewhat hazy brightening within the tendon substance itself without these clear secondary markers of acute injury.
Okay, that makes sense. And beyond the magic angle, we also need to be careful not to overinterpret just any minor signal change we see as being significant pathology, right?
Absolutely critical point. Choi and colleagues warned us specifically against this kind of overinterpretation. Their work showed that some degree of thickening and increased intrasubstance signal within both the SCL and the popliteus tendon are actually frequently seen in knees that are otherwise stable and might only have minor internal derangements, like a small degenerative meniscal tear, for example.
So just because the ligament looks a bit gray or slightly thicker doesn't automatically mean it's a clinically significant PLC sprain causing instability.
Correct. You absolutely must maintain critical judgment and correlate with the clinical exam. If you look at figure 10.3 in the source material, it actually illustrates this exact phenomenon, showing these signal changes in functionally stable asymptomatic volunteer knees. If you called every single one of those subtle signal changes a grade I sprain needing treatment or rehab, well, you'd be mismanaging a huge percentage of the population. Context is everything.
Okay, this is great. We've covered the language, the imaging. Let's shift our focus now and really start breaking down the key players, the actual structures within the posterolateral corner. Maybe we can go structure by structure, starting with what many consider the primary static stabilizer against varus opening, against the knee gapping open to the outside. Hashtag tagged FANHA A, fibular collateral ligament, FCL.
Sounds good. Let's start with the FCL, the fibula of the collateral ligament, sometimes just called the LCL, lateral collateral ligament. This is really the primary workhorse against varus instability.
Okay.
And understanding its specific anatomy is crucial for appreciating its function and injury patterns. It originates on the femur, specifically from a small bony prominence, slightly proximal and just posterior to the lateral epicondyle itself.
Proximal and posterior to the epicondyle. Got it.
And from there, it courses distally and slightly posteriorly to attach to a distinct small bony depression right on the lateral aspect of the fibular head. This is shown really nicely in figures 10.1 and 10.2 in this source.
Okay. Now, is there a key imaging feature, maybe a subtle sign related to its anatomical course, that can give us a clue about potential instability elsewhere in the knee?
Yes. There's a really neat clinical pearl related to that. Because the FCL naturally runs postero-inferiorly, its normal resting course is oblique relative to a standard coronal image.
Right.
So if, when you're just scrolling through your routine coronal images, you find you can easily see the entire course of the FCL, from femur to fibula, perfectly visualized on a single slice without needing any fancy reformatting. That can actually be a secondary subtle sign suggesting anterior tibial translation.
Anterior translation, meaning that the tibia has shifted forward.
Exactly. The tibia has shifted anteriorly relative to the femur, which pulls the fibular attachment forward, bringing the whole ligament into a more vertical, straight up and down plane relative to that coronal image slice.
Wow.
So seeing an unusually straight FCL on a single coronal cut should raise your suspicion for a potential ACL injury or maybe more global knee instability that's allowing that forward shift.
That is a phenomenal clinical pearl. Okay. Now, shifting to its failure pattern, which is obviously critical because it dictates treatment. Where does the FCL most commonly fail? Does it tear in the middle, pull off the bone?
It most typically fails right at its mid-substance, tears right in the middle of the ligament.
Okay, mid-substance.
And this distinction, mid-substance versus avulsion, is absolutely paramount for surgical planning. Why? Because mid-substance injuries are generally not amenable to primary repair.
Why not? Why can't you just sew the ends back together?
Well, a few reasons. The tissue quality at the torn ends is often compromised, sort of frayed like an old rope. And perhaps more importantly, the ligament ends tend to retract significantly due to the inherent tension. Trying to pull those retracted, poor-quality ends back together under normal tension is often impossible, or results in a repair that's too tight or too weak.
Makes sense. So if it's torn in the middle.
If it's a complete mid-substance tear causing instability, it generally requires a formal reconstruction using a tendon graft autograft, or allograft, to bridge the gap and restore stability.
Okay, reconstruction for mid-substance. How does that differ from the less common, but perhaps more satisfying to fix, avulsion injury pattern?
Right, an osseous avulsion, where the FCL literally pulls a piece of bone off its attachment, usually from the fibular head, is often amenable to primary repair.
Repair, not reconstruction.
Correct, because in that case, the ligament tissue itself is usually intact. It's just attached with its bony anchor. We can meticulously reduce that bone fragment back down to its original anatomical bed on the fibula and secure it firmly, often with suture anchors or maybe a small screw.
And that restores the native anatomy.
Exactly. It restores the native length and tension much more reliably than a graft reconstruction can,
All right.
potentially leading to better long-term outcomes when possible. Now, these FCL-related avulsion fractures, they tend to be larger bone fragments compared to the styloid fractures we discussed earlier.
Why large?
Because they typically also include attachments from the large biceps femoris complex, which inserts very close by on the fibular head. And as we mentioned with the arcuate sign confusion, this larger fragment involving both FCL and biceps may be visibly retracted proximally due to the pull of the biceps muscle.
Yeah.
Seeing that kind of fragment, as depicted in figure 10.14, is a key diagnostic feature.
So the size of the bone fragment and whether it's pulled proximally gives us a really important clue, not just about the FCL being involved, but also about the likely involvement of the biceps complex, confirming the need for a more comprehensive lateral structure assessment and potential repair.
Spot on. It tells you it's likely a significant combined injury. #TAG popliteus musculotendinous complex and popliteofibular ligament, PFL.
Okay, moving on from the FCL. Let's go a bit deeper now and talk about the popliteus complex. This includes the muscle, the tendon, and its associated ligament, the PFL.
Right. The popliteus complex. This is absolutely fundamental for posterolateral stability. It kind of plays a dual role, acting as both a dynamic muscle motor and also providing a static anchor through its attachments.
What's its main job dynamically?
Functionally, the popliteus muscle is a primary internal rotator of the tibia on the femur. It also acts as a key decelerator during gait, helping to pull the femur posteriorly on the tibia, which checks excessive external rotation, particularly as the knee comes into extension.
Okay, internal rotator and checks external rotation. And the tendon's course itself is pretty unique, isn't it? It's not just a straight shot.
It truly is fascinating anatomy. The popliteus tendon has this complex, almost corkscrew or helicoid course. It arises from the muscle belly down in the popliteal fossa, travels superiorly and laterally across the back of the joint, then dives intra-articular.
Intra-articular, inside the joint capsule.
Yes. It pierces the capsule posteriorly and runs inside the joint for a short segment as it courses anterolaterally, passing through the popliteal hiatus and the coronary ligament attachment of the lateral meniscus. It then exits the joint again to attach onto the femur, typically in a small fossa, just anterior and slightly inferior to the FCL origin on the lateral femoral condyle.
Wow. That intra-articular path seems like it would make it particularly vulnerable to injury during certain knee motions.
It does. Especially during forced external rotation or hyperextension injuries, that tendon can get impinged or torn as it wraps around the back of the femur.
So where do we typically see tears of this popliteus complex on imaging? Is it the muscle, the tendon, the attachment?
Tears most frequently involve the muscle belly itself, down lower in the calf, or at the musculotendinous junction where the muscle fibers transition into tendon. Those are probably the most common sites. However, we absolutely must be vigilant for tears of the tendon proper, including mid-substance tears along its intra-articular course, or complete femoral avulsions where the tendon pulls right off the femur. That femoral avulsion pattern is actually shown quite clearly in Figure 10.4 in the source material.
Right, so muscle belly, MT junction, tendon itself, or femoral avulsion. Got it. Now let's talk about the popliteofibular ligament, the PFL. This often gets described as the true anchor of the PLC. What defines its structure and, more importantly, its location? How do we find it?
The PFL is a distinct ligamentous band. It typically originates from the myotendinous junction of the popliteus muscle, where the muscle meets the tendon, and then it courses inferiorly and laterally to insert primarily onto the fibular styloid process, that pointy prominence on the top, back part of the fibular head. Specifically, it attaches at and just medial to the superior tip of the styloid.
Okay, MT junction of popliteus down to the fibular styloid. Now, you mentioned earlier there's a really key anatomical landmark for distinguishing things in the PLC.
Yes, and for the PFL, this is arguably the single most important anatomical landmark distinction in the entire posterolateral corner, both for imaging interpretation and for surgical navigation. The PFL is the only distinct ligamentous structure back there that consistently courses deep to the inferior lateral genicular artery.
Deep. Okay, so the artery is like our roadmap. If we see a ligamentous structure diving underneath that artery as it runs across the back of the knee.
That's the PFL. You found it.
And if the structure is running superficial or above the artery.
And it's something else, most likely the fibellofibular ligament or maybe some fibers from the biceps insertion complex, but not the PFL.
Okay, that relationship is non-negotiable, a critical point for standardized identification.
Absolutely critical. Now, in terms of failure patterns, much like the FCL, the PFL most commonly fails through its mid-substance, just tears in the middle. Figure 10.6 shows a nice example of that.
And mid-substance tear means reconstruction again.
Generally, yes. A complete mid-substance PFL tear that contributes to instability typically requires reconstruction, often done concurrently with an FCL reconstruction in what's called a PLC reconstruction procedure.
Okay. But what about the avulsion pattern? We talked about styloid fractures earlier.
Right. The avulsion pattern for the PFL is highly specific and clinically very important. When PFL avulsion fractures occur involving the fibular styloid, the bone fragment is characteristically small. Remember, we said 8 to 10 millimeters in length typically.
Tiny fragment.
Tiny fragment. And finding that specific small styloid avulsion fracture is highly predictive of an associated PCL injury. Our sources cite studies, like one by Ross et al., where they looked at 13 cases of these specific styloid avulsions, and all 13 were associated with a concurrent PFL tear, and importantly, a concurrent PCL tear as well. Figure 10.7 illustrates this pattern.
All 13. That's 100% correlation in that series. That is a critically important clinical link. So if I, as a resident, see that tiny little flick of bone off the fibular styloid on a trauma series X-ray or CT scout, my index of suspicion for a significant PCL tear should just skyrocket, even if maybe the posterior drawer test seems a bit subtle or difficult to assess in that acute painful phase.
Absolutely. That finding should immediately prompt a very careful assessment of the PCL, both clinically and on subsequent MRI, #C, anterolateral ligament, ALL, and second.
Okay, let's shift gears slightly and move from the posterolateral to the more anterolateral structures. And here we find the ALL, the anterolateral ligament. This is the structure that received just immense global attention following its really detailed anatomical description back in 2013.
That's right, the ALL. It's now generally accepted as a true distinct ligament, although on MRI it can often just appear as a subtle thickening of the lateral joint capsule, running obliquely from the lateral femoral epicondyle region down towards the proximal tibia.
And what's the biomechanical reason for its recent high profile? Why all the excitement about this ligament?
It really comes down to its function in rotational stability. Biomechanical studies have shown that the AL comes under significant tension. It gets tight, specifically during internal rotation of the tibia, especially near 30 degrees of knee flexion.
Internal rotation at 30 degrees, that sounds familiar.
It should. It acts as a critical secondary restraint to pathological internal rotation. And that specific combination of forces, anterior translation plus internal rotation, is the underlying mechanism of the pivot shift phenomenon, the clinical sign we look for with ACL tears.
Ah, the pivot shift connection.
Exactly. Its tibial attachment is located roughly halfway between Gerdy's tubercle laterally and the anterior margin of the fibular head, right in that anterolateral zone.
So that strong association with controlling the pivot shift mechanism directly links the AL to the most common severe ligamentous injury we see in the knee.
Yes, unsurprisingly, all L tears are strongly associated with ACL tears. Our sources confirm this high prevalence. Some studies report all L tears in upwards of 80–90% of acute ACL ruptures.
Wow, that high.
That high. And this is precisely why many surgeons, particularly in Europe initially, have integrated specific lateral extra-articular tenodesis or reconstruction procedures, often targeting the AL or the nearby ITB complex, into their ACL reconstruction protocols, especially for patients who present with a high-grade, clunking pivot shift preoperatively.
Because ignoring an AL tear, if it's present when you're just doing an isolated intra-articular ACL reconstruction,
it can potentially contribute significantly to persistent rotational instability after surgery. That feeling the patient has that the knee still gives way with cutting or pivoting motions, even with a stable ACL graft. And ultimately, that residual rotational laxity can lead to stretching or failure of the ACL graft itself over time.
Okay. And the classic failure pattern of the AL at its tibial attachment leads us directly to another well-known orthopedic eponym, the second fracture.
That's right. The second fracture, classically described from plain radiographs, is defined as that small osseous avulsion fracture off the anterolateral tibial plateau, right at or near the AL's tibial insertion site.
A little sliver of bone on the lateral side.
Exactly. Now, interestingly, this is actually another area of some active anatomical debate, similar to the arcuate story. Is the second fragment purely an avulsion of the AL? Some meticulous dissection studies support this view.
Okay.
However, other anatomical studies, particularly those looking closely at the complex insertions of the iliotibial band, provide evidence that some of the posterior-most fibers of the ITB also insert onto that same area and might contribute to the second fragment.
So it might be ALL, might be ITB, might be both.
It might be a combined structure avulsion.
Yep.
But regardless of the exact fiber origin, the presence of a second fracture on imaging is a near pathognomonic sign of a significant underlying ligamentous injury, almost always an ACL tear, and signifies a major failure of the anterolateral restraints against excessive internal rotation.
Okay. Now, given its relatively small size and its oblique course, actually visualizing the ALL reliably on imaging must present a significant challenge, even with those fancy 3D sequences we discussed.
It absolutely does. Reported visibility rates in the literature range wildly, sometimes cited as low as 51% and sometimes up to 100%, depending on the study, the sequence used, and the criteria for identification.
That's huge variability.
It is, and it really underscores the difficulty. Figure 10.10 in our source material, especially looking at panels A and B together, perfectly illustrates the necessity of using those 3D reformatted images. On a standard coronal slice, panel A, you might see some apparent signal irregularity or maybe even what looks like discontinuity in the expected region of the AL, potentially leading you to overcall a tear.
Right. Looks torn on the standard view.
But then, when you take that 3D dataset and specifically reformat the image directly along the anticipated course of the ligament, panel B, suddenly the structure looks continuous and intact.
Ah, the oblique view clarifies it.
Exactly. That ability to reformat the image along the ligament's true axis is absolutely critical for accurate diagnosis of all injuries, helping us avoid both false positives, calling a tear when it's just partial volume, and false negatives, missing a subtle tear because we didn't look in the right plane. #tag D biceps femoris complex.
Okay, let's move slightly more posteriorly again and tackle the biceps femoris complex. Now, this is far more than just a simple hamstring muscle that flexes the knee, isn't it? It seems like an incredibly complex architectural masterpiece of stabilization back there.
It is incredibly complex, you're right. It's composed, of course, of the long head coming down from the ischium and the short head arising from the femur. These merge and then divide near the knee into various inserting arms. But crucially, the long head also contributes 3 distinct fascial components that splay out the lateral aponeurosis, a reflected component, and an anterior aponeurosis.
3 fascial layers from the long head.
Yes, and these fascial layers integrate intimately with the surrounding tissues, including the IT band and the lateral capsule, making them vital stabilizing structures in their own right. It's not just about the main tendon.
Okay, Let's maybe focus in on the short head components, as those seem most directly relevant to the PLC structures we've been discussing.
Good idea. The short head, as it approaches the fibular head, features two particularly vital inserting arms. First, there's the capsular arm. This provides a broad sheet-like attachment onto the posterolateral joint capsule itself.
Okay, blending with the capsule.
And importantly, the thickened distal edge of this capsular arm is anatomically defined as the fibular ligament, or FLFL, which we mentioned earlier. This FL component specifically inserts onto the fibular styloid, just lateral to the PFL insertion, and remember, superficial to the artery.
Got it. Capsular arm includes the FL, superficial to the artery. What's the second arm from the short head?
The second key structure is often called the biceps capsuloosseous iliotibial tract confluence.
That's a mouthful.
It is, but it describes a critical connection point. It's where fibers from the short head tendon, the posterolateral capsule, and the deep layers of the ITB complex all merge together and insert onto the bone near the fibular head. It's a key linkage structure. Figure 10.11 in the source provides a really stunning illustration of this layered integrated anatomy back there. It's beautifully complex.
Okay. Now, you mentioned the fibular ligament, the FLL, as part of the capsular arm. This ligament seems notorious in the imaging community. Anatomically, it's supposed to be present in essentially everyone, right?
That's correct. Dissection studies show it's a consistent structure.
But diagnostically on MRI, it often seems like a ghost. Why is it so hard to see?
Well, partly it's just small and thin. But the main reason is that its MRI visibility on conventional 2D sequences is historically quite poor. Studies report ranges anywhere from 0% visibility up to maybe 48% at best.
0%. So sometimes it's just completely invisible on standard scans.
Apparently so. In some series, its size and thickness, and therefore its visibility, often seem to correlate with whether or not the patient has an ossified fibella, that little sesamoid bone, in the lateral head of the gastrocnemius.
Ah, the fibella connection. If there's a fibella, the FFL is usually thicker and easier to spot.
That seems to be the general observation, yes. The fibella acts like an anchor point for it.
Okay. And reminding us again, how do we definitively confirm its identification, especially when we're trying to differentiate it from the nearby PFL, which has a similar trajectory towards the styloid?
We go right back to our crucial anatomical map, the inferior lateral genicular artery. The FFL is consistently situated superficial to that artery.
Superficial.
Above the artery.
That is the anatomical litmus test. If the ligament is deep, it's the PFL. If it's superficial, it's the FFL, or potentially other biceps fibers.
And because it's often thin and hard to see clearly, diagnosing pathology like a tear of the FL itself is also quite difficult unless you can visualize clear, unequivocal signs of a tear, for example, seeing the retracted torn edges, perhaps with associated fluid signal. Figure 10.3 shows an example of a soft tissue avulsion involving the FFL, where you can see that disruption. But subtle interstitial tears are very challenging to call confidently.
Okay. But that clear contrast FL superficial to the artery, PFL deep to the artery, that remains the absolute anchor point for correctly labeling these different ligamentous injuries on advanced imaging.
Couldn't emphasize it more. That landmark is key. Hashtag isotibial band. ITB.
All right, last but certainly not least in our tour of the lateral structures, iliotibial band, the ITB. And I think we really need to dispel the common notion that this is just a simple, singular band of tissue running down the side of the thigh.
Absolutely. It's far more complex than that. It's really a highly specialized, thickened region of the deep fascia of the thigh, the fascia lata, and it's absolutely essential for providing dynamic lateral stability to the knee, working in concert with the gluteus maximus and TFL muscles proximally. And remember that staggering prevalence number we mentioned earlier.
58% injury rate in acute knee trauma cases. Just huge.
Huge. Which means we need to understand its anatomy well.
So why is understanding the detailed anatomy, specifically its different layers at the knee, so crucial for the surgeon planning a repair or reconstruction?
Because the different layers have different insertion points and potentially different roles, and they can be injured selectively. Broadly, the ITB complex at the knee is described as having superficial, deep, and sometimes a capsulosus layer.
Okay, let's start with the superficial layer. That's the one we usually think of.
Yes, the superficial layer is the most prominent, the one we typically palpate. It courses down and inserts primarily onto Gerdy's tubercle, on the anterolateral aspect of the tibia. Figure 10.15a shows that main insertion nicely.
Gerdy's tubercle.
Okay.
But this superficial layer also has a really critical anterior expansion, often called the iliopatellar band. These are arciform fibers that sweep forward from the main ITB to attach onto the lateral border of the patella and the patellar tendon.
Iliopatellar band, so it connects the ITB to the kneecap.
Exactly. And this plays a huge role in lateral patellofemoral stability, helping to prevent excessive lateral tracking or dislocation of the patella. Figure 10.15b highlights this iliopatellar component.
Okay, so superficial layer to Gerties and the patella. What about the deep layers? These seem to be implicated more in the posterolateral instability picture.
They are indeed. The deep layer of the ITB is less distinct visually, but functionally important. It originates more posteriorly, partly from the linea aspera and the lateral intermuscular septum of the thigh, and it has complex attachments down around the lateral femoral epicondyle and blends with the capsule.
And the distinction between carrying the superficial versus the deep layer, that's clinically significant. Profoundly important, based on the work cited. In patients who had severe surgically confirmed grade 3 PLC injuries requiring surgery, Laprade's group found that tears involving the deep layer of the ITB complex occurred in a massive 71% of those operative cases.
71%. Wow. Compare that to the superficial layer.
In the same cohort of severe PLC injuries, only 14% had significant involvement or tearing of the main superficial layer inserting onto Gerties.
That is a staggering clinical metric. So the deep layer tear seems to be the real marker of severe lateral-sided injury.
It appears to be. If the imaging report just mentions edema around the ITB, but doesn't specifically comment on the integrity of the deep layer attachments near the femur or the septum, you might potentially miss the true high-grade instability pattern that might benefit from a more comprehensive lateral reconstruction or augmentation procedure.
So the deep layer injury is kind of the real smoking gun for that severe, potentially chronic instability developing.
That seems to be the implication, yes. While MRI often shows edema fluid tracking along both the superficial and deep sides of the ITB in acute injuries, identifying specific disruption of those deep layer fibers, often occurring near the lateral intermuscular septum attachment, as suggested in figure 10.16, that might be the high-stakes injury we really need to detect preoperatively.
Makes sense. And I suppose you can also see avulsion fractures of the ITB insertion.
Yes, though less common than CBD. Second fractures, you can occasionally see avulsion fractures of Gerties tubercle itself, where the main superficial ITB pulls off its tibial attachment. That indicates a pretty catastrophic failure of the entire ITB complex. Figure 10.17 shows an example.
Okay, we have spent a considerable amount of time, justifiably so, on the complex lateral side, the PLC. But before we wrap up, we absolutely must emphasize that the medial side, the posteromedial corner, or PMC, is arguably just as crucial, particularly when we're dealing with those complex multiligamentous knee injuries or trying to figure out sources of chronic instability.
Absolutely agree. The medial side is often underestimated, perhaps seen as simpler than the lateral side, but its job is absolutely vital. Its primary role is preventing anteromedial rotational instability, or AMRI.
AMRI.
The PMC essentially comprises the structures lying between the posterior margin of the main superficial MCL and the medial border of the PCL insertion. And just like the PLC, if significant injuries to the PMC are overlooked, missed, or allowed to stretch out and become incompetent, they lead to excessive anterior translation and, importantly, excessive external rotation of the medial tibial plateau relative to the femur.
And the downstream consequence is the same as on the lateral side, potential graft failure.
Exactly the same. That residual medial side instability introduces abnormal shear and rotational forces that can overload and eventually destroy an otherwise perfectly placed and tensioned ACL or PCL reconstruction. The foundation, the platform, must be stable on both sides for the cruciate grafts to function properly and survive long-term.
Okay. Can we briefly run through the traditional three-layered anatomy concept for the medial side? It seems like a helpful way to organize those structures.
Yes, that layered approach, often attributed to Warren and Marshall, is a very helpful framework for conceptualizing the PMC structures, although like all anatomical models, it's a bit of a simplification.
Sure.
But generally, layer 1 is the most superficial layer. This includes the deep crural fascia and, importantly, the overlying tendons of the pes anserinus complex, the sartorius, gracilis, and semitendinosus, as they sweep around to insert on the anteromedial tibia.
Layer 1, fascia and pes tendons. Okay.
Layer 2 is often considered the critical structural layer. This layer includes the main superficial medial collateral ligament, SMCL, the big strap-like ligament we all know, and also, more posteriorly, the oblique popliteal ligament, OPL, which reinforces the posterior capsule.
Layer 2, superficial MCL and OPL. Got it.
And then layer 3 represents the deepest structures. This includes the joint capsule itself, the smaller deep medial collateral ligament, DMCL or medial capsular ligament, and crucially the complex distal insertions of the semimembranosus tendon complex. Figures 11.1 and 11.2 in the source provide nice schematics of these layers.
Okay, so if layer 1 is mainly dynamic flexion support from the pes tendons, layer 2 provides the primary static and dynamic rotational control via the SMCL and OPL, and layer 3 is that deep capsular restraint plus the semimembranosus anchor. Is that a fair summary?
That's a very good functional summary, yes. Injury to layer 2, specifically tearing the SMCL and potentially the OPL, is what typically causes the gross valgus instability, gapping open medially, and that anteromedial rotational laxity we test for clinically.
Right.
But arguably the most sophisticated structure on the medial side, and certainly the most important dynamic stabilizer of the PMC, is the semimembranosus tendon complex.
The semimembranosus. Another hamstring muscle, but its insertion seems incredibly complicated down at the knee. It's described in the sources as having no less than 5 anatomically distinct tendinous branches or arms that insert into that posteromedial region.
5 distinct arms, exactly. It's not just one simple insertion point. And these multiple arms attach to different structures back there, acting together like a dynamic check rein and a static anchor for the posteromedial corner. Understanding these 5 arms and appreciating their combined role in dynamic stability is really essential if you're contemplating surgical repair or reconstruction on the medial side.
Okay, let's try to quickly name and maybe understand the function of those 5 arms. What's the main one, the direct arm?
The direct arm is generally considered the principal strongest component. It provides the main tendinous insertion onto the posterior aspect of the medial tibial condyle, specifically onto a little bony prominence called the tuberculum tendinus. This provides the primary static anchor point for the muscle's pull.
Okay, direct arm, main anchor. What about the arm that extends to the OPL?
Right, the extension to the OPL. This is a really key functional component. It's a slip of tendon that runs from the main semimembranosus tendon superiorly and laterally to blend directly with the fibers of the oblique popliteal ligament.
OPL.
So it connects the muscle to that ligament.
Exactly. So when the semimembranosus muscle contracts, it actively tensions not only its direct tibial insertion, but also the OPL via this connection. This makes the OPL a critical dynamic restraint against knee hyperextension and external rotation, actively tightening when the hamstring fires. It's like having an active check strap on the back of the knee.
That's clever anatomy. Okay, then we also have the capsular arm, the anterior arm, also called the pars reflexa, and the inferior or popliteal arm. What do they do? The anterior arm, or pars reflexa, is a significant band that courses anteriorly, running deep to the MCL, and contributes fibers to the medial meniscus and reinforces the anteromedial joint capsule near the tibia. The capsular arm is essentially the broad expansion that blends directly with the posterior joint capsule itself, reinforcing it, and the inferior, or popliteal arm, courses inferiorly along the back of the tibia towards the soleal line, blending with the popliteus fascia.
Wow. So this multi-arm structure ensures that when the semimembranosus contracts, it doesn't just flex the knee, it simultaneously tightens the posterior and medial capsule, actively tensions the OPL and pulls on the tibia, thereby resisting valgus and rotational forces dynamically.
Precisely. It's a very elegant and crucial dynamic stabilizing system.
Imaging this 5-pronged insertion must be challenging, though, especially trying to differentiate between just normal anatomical complexity and actual pathology like a tear.
It is complex, definitely. On MRI, for instance, the anterior arm and the direct arm often appear quite close together, sometimes forming what looks like a single inseparable low signal intensity band running along the posteromedial aspect of the tibia.
Okay.
And one key imaging note, a potential pitfall to avoid false positives. On axial MR images, it's quite common and considered a normal variant to see a small amount of fat signal accumulating between these different tendinous arms right down near the joint line.
You might see a little bright streak of fat between the dark tendon slips.
Exactly. And you shouldn't mistake that normal interstitial fat for abnormal fluid signal indicating a tear or retraction. Figures 11.3 all the way through 11.9 in the source material do a good job demonstrating the normal MRI appearance of these different arms and that potential for normal fat signal between them. As always, we really have to understand the normal complexity intimately before we can confidently define pathology.
Well, this has been an incredibly detailed, really fascinating review of the knee's sort of hidden architecture, the corners.
It's dead stuff for sure.
Yeah, it is. But if we look back at our sources and our discussion, it feels like 3 really critical takeaways emerge for the clinician listening. First, That injury prevalence shift is just undeniable, isn't it?
Absolutely.
PLC injuries are highly common, not rare curiosities, and ITB injuries are involved in well over half of acute knee trauma cases. This makes a comprehensive assessment of both corners basically mandatory with every significant ACL or PCL tear you evaluate.
Couldn't agree more. Second, the imperative for standardizing our language has to be recognized and acted upon. That historical ambiguity surrounding terms like arcuate, whether you're talking about the ligament or the sign, it's a genuine barrier to accurate, timely surgical planning.
Right.
We absolutely must adopt descriptive, standardized, attachment-based terminology,
Mm-hmm.
use those reliable landmarks like the inferior lateral genicular artery to consistently distinguish structures like the PFL from the FLL. Clear communication saves time and prevents errors.
And third, the visualization problem. Seeing these structures, it's really only solved by advancing our imaging technology and protocols. Standard 2D sequences, as we discussed, they simply do not possess the required through-plane resolution to consistently and accurately capture these small, oblique, yet critical stabilizing ligaments of the PLC and PMC.
Mm-hmm.
High-resolution 3D isotropic imaging protocols like SPACE, CB, VISTA, they are essential now for defining this complex anatomy in, as the source says, exquisite detail.
And that leads perfectly into the overarching clinical takeaway, which kind of ties all these points together. It's this. While the ultimate decision for if surgery is needed always rests on a thorough clinical examination assessing functional instability.
Right. Exam is still king for the if.
Exam is king for the if. But optimized MRI protocols using these 3D sequences combined with a deep understanding of this standardized detailed anatomy are absolutely essential for diagnosing the exact pathology with that exquisite detail. And why does that detail matter? Because proper preoperative planning means identifying the specific location of failure.
The what and where.
Exactly. Is it a mid-substance tear of the FCL or PFL, which, as we said, generally mandates reconstruction due to tissue quality and retraction? Or is it a clean osseous avulsion off the femur or fibula, which might change the treatment entirely to a primary anatomical repair?
And that distinction fundamentally changes the whole surgical approach, the implants needed, the rehab protocol, and ultimately the patient's prognosis.
Fundamentally, you have to know exactly what you're dealing with before you go in.
Okay. And that detailed understanding leads us perfectly into our final provocative thought for you, the listener, to consider before our next deep dive. Here it is. Given the really complex biomechanical tension and the intimate relationship we've discussed between the interconnected restraints on the lateral side, specifically thinking about the anterolateral ligament, ALL, the deep layers of the ITB, and their combined role in resisting that pivotal internal rotation, what are the potential long-term kinematic implications if we rely on a non-anatomic repair or maybe just a simple augmentation procedure when dealing with injuries to this complex?
Think about that.
We already know that standard, isolated intra-articular ACL reconstruction sometimes fails to completely control rotational instability in certain patients, especially those with high-grade pivot shifts. So the question is, does the subtle integrity or lack thereof of that LL deep ITB complex perhaps hold the key to truly normalizing knee kinematics after injury and, maybe most importantly, protecting our expensive, perfectly placed cruciate ligament grafts from those detrimental rotational forces over time?
Something to definitely mull over. Consider the geometry, the interplay, the mechanics involved. We'll leave you with that until next time.
Thanks for joining us. We'll catch you on the next deep dive.